two, one, we can start.
Okay, thanks. Good evening, everyone. I welcome you all for this scientific meeting. On behalf of Bayer, I welcome you all. So, for today's evening, we have our moderator, Dr. Supreet Juneja, sir. Sir has more than 17 years of experience, and sir has done his fellowship from Arvind Eye Care Institute, and sir has been associated with many reputed institutes like Venu Eye Institute, SAP Center for Sight, and currently sir is working at Sunetra Eye Institute at Ghaziabad. Without any further ado, I will request Dr. Supreet Juneja sir to please start the meeting.
Thank you, Mr. Dinesh. First of all, I would welcome all the speakers. Thanks, Bear, for giving us this platform for this kind of interaction, which will enable us all to have a little more knowledge, little more experience in taking the clinical insight to our patients. So there are three speakers, I suppose, today, Dr. Apur Grover, Dr. Rohan Kapoor, and Dr. Riddhi Arya. Dr. Apur has been with me also in Arvind Eye Hospital, Madurai. He has been a consultant at Sadhguru Nedh Chikitsalaya, Chitrakoot also. He has been part of several instruction courses with the annual conference of All India AIOS, speaker and faculty at various international and national meetings. And he is also examiner and fellow of the prestigious Royal College of Ophthalmologists, London, for the past several years. Dr. Rohan completed his medical education, MBBS and MS at the Christian Medical College and Hospital, Ludhiana, earning the prestigious Alien B. Snow CMC Alumni Award for Best All-Rounder Graduate in 2016. Dr. Kapoor further honed his expertise through long-term clinical fellowship in retina and vitreous surgery at renowned L.V. Prasad Eye Institute, Hyderabad. He has presented numerous papers. He was invited as a a guest speaker at the prestigious third Eggleston Memorial Oration. His commitment to advancing eye care is evident in ongoing research projects and dedication to its patient well-being. And last but not the least, Dr. Riddhi Arya is a renowned and experienced ophthalmologist at Adi Shankar Eye Hospital, Varanasi. She brings with her an experience of 10 plus years and has been associated with some of the best hospitals in the Dehradun. So without further wasting time, let's start with our first speaker. Is it Dr. Apur?
I can start if you suggest. Yeah? Okay.
Yeah, please.
Okay, I'll be sharing my screen. Just a minute. Yeah. Is my screen visible?
Yeah.
Yes, sir.
Okay, perfect. Thank you for the kind introduction, Supreet sir. It has been a pleasure working with you. So much we've learned in Madurai and hope to continue learning from you. Yeah, so I'll be presenting a couple of challenging cases, mostly wet AMD, which I've been treating with Eylea lately. This is my first case. It's a 52-year-old lady who presented to us with fluid and distortion of vision in her left eye. And we did the OCT where we found a complex just temporal to the fovea hair with some stipple leakage late in the fundus fluorescein angiogram, and we diagnosed her with a wet AMD at this stage, and we started treatment with ranibizumab injection, and she started very well to begin with, and for almost nearly 2 to 5 years we maintained her on ranibizumab. This was after one of the exacerbations where she came. You can clearly see an orangish nodular lesion here, probably suggestive of a PCV lesion, and there is some hemorrhage at the superior border and a subretinal hemorrhage at the inferior border. So again, treated with ranibizumab at this stage, and after 5 years with ranibizumab, she is well controlled. All her fluid is gone. Her vision is 6/9. However, at this stage, when she came for a follow-up the next visit, you can see that some fluid has come back, and there were also some hard exudates at the edge of the irregular PED, probably suggestive of a polyp, and some intraretinal fluid as well. And then we treated her with ranibizumab again at this stage. However, you can see when she came for her next visit, which was slightly delayed about 6 weeks later, the fluid instead of reducing has increased. IRF has increased, some SRF has also increased, and her vision also deteriorated to 6 by 12. Again, we treated her with ranibizumab, and again she came 7 weeks later. Some Shrem has also come, other than fluid, and there is no improvement in her vision. Admittedly, she's also coming for a delayed follow-up, not coming for a follow-up every month as we had suggested. And again, we repeated the injection. The fluid is persisting. So after at the end of three ranibizumab injections, her fluid is still persisting. Vision has not improved. It has gradually, in fact, deteriorated to 6 by 18. So this is when we switched her to Eylea, aflibercept, and after the first injection itself, she came for a follow-up after 6 weeks, even though she was advised to come for after a month for a follow-up. You can see that the fluid is all gone. With the one Eylea injection itself, the fluid is all gone. Some hard exudates are still there at the border of the lesion, which were present even before the Eylea injection when we were treating her with ranibizumab. And after again, she comes for a delayed follow-up, and the fluid has come back again at the edge of the PC polypoidal lesion, and even at the fovea fluid, subretinal fluid, and IRF also at the fovea. And again treated with Eylea, came again for a delayed follow-up at 10 weeks, and the fluid is still persisting. Vision at this stage is still 6 by 18. So we've been throughout counseling her that you need to come for a more regular follow-up, and it is absolutely essential that you do not delay the follow-up. Although we had advised her to come for a follow-up after 4 weeks, she did come for a follow-up at 8 weeks, which was even further, which was delayed, but you can still see the effect persisting at 8 weeks. The fluid is all gone with as we continued treating her with aflibercept, and after a couple of injections, the fluid has completely resolved, and the BCVA has improved to 6 by 12. And now we are maintaining her on 8 weekly Eylea injections, and thankfully she has also been coming for regular follow-ups. And I'm for probably the next visit, I'm planning to increase the duration slightly between Eylea injections and see to 10 weeks and see if the fluid is coming back. So to summarize, this was a 56-year-old lady at the end of her last follow-up, who initially responded very well to ranibizumab and was well controlled with PRN therapy. However, during the course of therapy, she stopped responding to ranibizumab, and you can see that her response with aflibercept was much better. However, we did stress the need for frequent and regular follow-up and injections, which will be needed even if she is being treated with aflibercept. If you extend the treatment interval beyond 10 weeks, then the fluid tends to come back and the vision also starts deteriorating. This is my second case. This was a 79-year-old gentleman, wet AMD. We initially started the treatment with ranibizumab, what is responding well. At the end of 2 years, his visual acuity is maintained at 6 by 9. You can see there is still some subretinal fluid which has come back, and was told to continue treatment. However, this patient moved overseas and was treated elsewhere for the condition, came back to me nearly 14 months later. And here you can see that not only the height of the PED has increased, but there is some amount of scarring and fibrosis, and there is subretinal fluid at the fovea. There is a choroidal cleft as well underneath, suggestive of an active disease, and the visual acuity had deteriorated to 6 by 24. In spite of the fact that he said he was being treated with aflibercept every 2 months or so. So we did counsel him that you will initially need monthly injections to control the disease, and once it is controlled, then we can probably increase the duration between injections. So you can see that after the first injection, the fluid has slightly started to come down, further come down after the second injection. And then after 3 injections monthly, the fluid is nearly completely resolved. Although the PED is still persisting and there is some amount of fibrosis which has already come about. His visual acuity at this stage is 6 by 12. However, the patient was not willing to continue with monthly injections. After 4 injections, 6 by 12 vision is there. However, he still says, I have not been able to achieve the vision in spite of us counseling him that he may not regain full visual acuity that he had before. He is unhappy with his vision and he wants a longer duration drug. He is not willing to come for monthly follow-ups and he says, I want a longer duration drug at this stage. So we tried a faricimab injection at this stage. However, at 6 weeks, when he came for the next follow up, you can see that the fluid at the edge of the AMD has come back, and his visual acuity, instead of improving, has actually deteriorated from 612 to 6 by 18 when we switched to faricimab. So at this stage, once again, he's felt that vision is deteriorating. So he wanted to come back to Eylea injection. And we convinced him to come back to Eylea injection at this stage. And again, you can see that there is good response at 5 weeks post injection, although there is still some fluid at the border of the CNV. And once we treated him with Eylea again, he came for a slightly delayed follow-up at about 7 to 8 weeks. He received the next injection at 8 weeks at this stage. However, after again a delayed follow-up of about 7 to 8 weeks, the fluid is actually increasing and his vision is further deteriorating in spite of the fact that the injection has been repeated at 2 months. So at this stage, we had a conundrum how to further proceed with the management, whether to continue with aflibercept injection and call him for more frequent injections, probably every 4 to 5 weeks or so, or considering switching to another anti-VEGF agent like brolucizumab or faricimab, or the other option is to increase the dose of Eylea injection itself, or maybe consider Eylea HD. However, that is not available in India at the moment, as we all know. So we eventually decided to continue with Eylea injection. However, once again, his follow-up was delayed. This was at nearly 16 weeks. There is no improvement in vision and fluid, intraretinal fluid is still persisting. There is some amount of SHREM as well. We re-injected Eylea at this stage. When he came for a follow-up at 8 weeks, you can see that the fluid has started to come down. Again, re-injected with Eylea at 8 week follow-up. Once again, the fluid is gradually coming down. The SHREM has come down, although some amount of fibrosis and scarring has already set in. And then following the next Eylea injection, when he was called for a follow-up at 4 week, 1 month, he came for a follow-up at 6 weeks, slightly later than we had called him. And you can see that the fluid has completely resolved at this stage. His visual acuity is 6 by 12 partial. So as we increase the frequency of Eylea injections to 7 to 8 weeks, he tends to respond very well, and the fluid even has completely resolved at this stage. So we are now continuing him with Eylea injections every 8 weeks or so. And yeah, if the fluid continues to remain elusive, then we may consider slightly increasing the duration between injections. Yeah, so I think we can end with 2 cases here. Sorry. This is my final slide. Yeah, do we have more time? Dr. Supreet? Hello?
Yes, sir. We can have another. If you have ready-made cases, so then we can go.
Okay.
One more
Okay,
case.
I have, yeah, I want to present one more case here.
Yeah. Go, sir.
Although
Please
this is
present
not
one more.
strictly, yeah. We have, this is not strictly wet AMD. This is a CNV in a young patient who is on treatment overseas. And he was on treat and extend Eylea. When he came to me, he has some fibrosis at the edge of the fovea. His vision is 6 by 6, but he's complaining of metamorphopsia. The cause of CNV in this patient is not known. Possibly he had some history of CSR which he doesn't remember. And vision at this stage is 6 by 6. He was being extended, the treatment interval between injections was being gradually extended. So I continued to treat him. At this stage, injection was given at a gap of 12 weeks, following which the disease continued to remain dry for a significant amount of time, and then we stopped. Since this was not a typical wet AMD, we ended up giving him a longer gap between injections, and since he remained dry, we did not inject for a long duration of time, and he remained stable for nearly 2 years. However, came with an exacerbation after 2 years, where he you can see that the size of the complex has increased. Says after 2 years came back to us, yeah, although his vision was still 6 by 6, and there is some fluid at the edge of the complex as well, slight bit of fluid, and there was a hemorrhage, overlying hemorrhage at the complex as well. This was nasal to the fovea. So we again treated him with the Eylea injection, and the complex tends to, following injection, the fluid has resolved, the hemorrhage has resolved, and the complex also tends to shrink back further to nearly its previous size. So, yeah, just a few points of discussion in this case. We don't know the cause of CNV, why such a young patient developed CNVM. The other eye is completely normal, the fundus is normal, asymptomatic. And what would be the ideal follow-up and treatment regimen in this patient who's, not developing exacerbation for so long, and then suddenly 2 years later, he comes with a hemorrhage and metamorphopsia. We did stress the need for a regular follow-up every 2 months or so, and to for the patient to self-monitor on Amsler grid chart if he feels there is any deterioration in vision or any metamorphopsia which is getting worse. So yeah, these are my 3 cases. Thank you. We can have a discussion now.
Thank you, Dr. Apur, for a good
Thank
number of
you.
cases and a good amount of follow-ups you are showing with your cases, basically. Uh,
Thank you, sir.
there are
There is
few.
some issue with my video. I think my video is not turning on. I hope my slides were visible
Yeah,
clearly.
yeah, the slides were visible.
Yeah. Yeah.
Okay.
Thank you. Any points of discussion? Any questions, sir?
Regarding your first case, I just need to ask few things. One
Yeah.
is you told us that there was a PRN therapy going for another for 2 or 3 years with the Razumab,
Yes.
ranibizumab. What is the
Razumab only.
PRN basically in that? Means every 3 monthly or something like that, or how often the follow-up was there? Because
Follow-up
like
was there monthly.
monthly.
But the patient obviously, although we called her monthly, she did not come every month. She would
Hmm.
sometimes come at 6 weeks, sometimes at 8 weeks, and every time I saw any fluid, I would inject. And the
Oh.
fluid would also resolve with injection. Her vision would come back, but yeah, after a certain stage, after a few years, somehow her fluid kept on getting worse in spite of giving ranibizumab, and then we switched her to Eylea.
Can you put on
Yeah.
the slides again?
Yeah. Yeah, so this was 5 years after PRN treatment with ranibizumab. She is
Okay.
still dry and vision is 6 by 6. And then this is an exacerbation after when she comes for the next follow-up.
We are not able to see the slides.
Yes, sir. Slides are not shared, I
Okay,
think.
let me share again. Is it seen now?
Yeah. Yes, sir. I just wanted
Yeah,
to ask because
yeah.
first
So,
one I thought probably the patient was incompliant, which happens in most of our clinical practice.
yeah. So
So,
follow-up at each
hmm,
visit is slightly delayed. Although I call
yeah,
her after a month, she comes sometimes at 7 weeks, sometimes at 6 weeks. Yeah,
because what I could see from here, it's basically there all the negative markers. The persistent IRF is there,
yeah,
the SHREM is there, hyperreflective foci are there.
yeah.
So all these are basically the negative markers which actually point us in the direction that we have to have very aggressive treatment in these cases so as to have a long-term remission. And
Yes.
ideally, yes, treat and extend can be done in such kind of cases, but only after an aggressive treatment of say 3 to 5 injection at monthly intervals, followed later on by treat and extend by
Yeah,
extending it every 2 weekly or something like that, so
yeah,
that by
yeah.
the end it shouldn't be more than say 12 weekly.
Okay, yeah. So this is nearly 5 weeks after she has been on treatment. And at each
But
of these visits, she is being injected with ranibizumab. But in spite
okay.
of that, her fluid is increasing.
But again, the point is, it was kind of
The follow-up is
treated.
delayed.
The follow-up is delayed most of the time.
Yes.
That's why even that didn't work. Yes,
Yeah.
aflibercept works in a much better way in comparison to, say, ranibizumab in such circumstances. But again, aflibercept also needs to be given, say, monthly first the loading doses, at least 3 to 5 loading doses. After all, yes, we can go for in with such kind of biomarkers, persistent IRF, SHRM, hyperreflective foci kind of thing, with the PED, yes, of course, we need to be a little more
Yes.
aggressive with this.
Yeah. Yeah. Agreed. Yes. So follow-up even with when we switched her to aflibercept, we should have given a loading dose of three
Yep, yep.
injections. Yeah.
Any comments, Dr. Rohan? What else?
No, I think I mean the cases are very good. I mean, you have a very long follow-up, Dr. Grover.
Hmm.
This is what we face in our
Thank
day-to-day
you.
clinics. You'll ask the patient to come after 4 weeks, they'll come after 8 weeks. That is what I'll show through my cases also. Even if you're
Yeah.
planning a very very meticulous loading dose regimen followed by a treat and extend, and most of them they just do not follow it. And yes, they usually, after some injections, they know that, okay, they have to report when the vision gets reduced or when they notice that metamorphopsia. So even the patient knows that, okay, I need injection now, I should go back. And that is when they come to us.
Yes, exactly.
True.
Uh,
I
so
just
this
had
was
one
about,
doubt. If I may ask, sir, when do you plan to switch your injections? Like after how many injections? I mean, nobody can give us a very, sure short answer. But in your clinical practice, when do you decide to switch your injection when it comes to wet ARMD?
uh, Dr. Rohan, most of the time when I start with the aflibercept, very rarely I have seen that I need to switch it off or change to the another injection. But yes, when starting with the ranibizumab, after 3 or 5 injections, minimum 3 injections is my criteria. 3 injections, less than say 25% reduction in the OCT findings, persistent IRF, even small amount of hyperreflective foci, again appearance of SHREM and all. These are, especially the IRF is one thing which I noticed very carefully, that if there is persistent IRF, even after say second injection or third injection, by the third injection, I mostly have made up my mind ki nahin, ye will have to change it. Because these days, actually, there is a plethora of anti-VEGF available. So, and the patient doesn't have even that much time or patience, considering the economics involved and everything like that. You have to be little more aggressive these days. So by second injection, or say by the end of second OCT or third OCT, I mostly come to the conclusion whether this patient needs a more aggressive follow-up, because a lot of times it happens like we all were talking in this terms. The patient we ask for 4 weeks, patient comes after 5 weeks, patient comes after 6 weeks. So when we start injecting the injection at the very first onset, I tell my patients for these loading doses, you have to be there before 30th day. We have to inject the next dose before 30th day. 28 days or 4 weeks, I tell them maximum key we will be doing the OCT at before the end of 4 weeks. So we'll be deciding and going ahead with the next injection by that time. So by the end of 2 injections and probably the third OCT, I mostly make up my mind for that.
All right, sir.
And when you switch, do you give a loading dose usually?
No, but switching, I don't give a loading dose. However, I mostly go for treat and extend. That is my usual
Okay.
practice in clinical cases. I go for treat and extend, but sometimes I'd go for, say, if the patient, like in your first case, which you showed,
Yeah.
I normally treat and extend by 1 week interval only. I don't go for 2 weeks or 4 weeks treat and extend. I go for 1 week. This time 4 weeks, the next time 5 weeks. If next time 5 weeks it is going fine, next time 6 weeks. Or maybe 6 weeks पे दो maintenance dose दी, then go for 7 or 8 weeks. But my
Yes.
maximum is say 12 weeks, not more than that.
Even with Eylea.
Even with Eylea, I try to be 12 weeks. 12 weeks में अगर जरूरत नहीं पड़ती, then my follow-ups to the patient becomes more stringent. Say, I don't call them after say month or 2 months interval. Then I call them
Hmm.
monthly or 3 weekly just to check whenever they need it. Because we know at the end of 3 months period or 12 weeks period, the chances of giving injection or the chances of return of the disease is say much more rampant, especially in the cases of PCV. We all learn by sometimes burning our hands with that, because sometimes we might have left certain patients for say 12 weeks, 14 weeks, and suddenly they come with a huge subretinal bleed and huge say macular bleed like that. And one thing
Yes.
about your second case was there were when you switch on to faricimab, we have seen a small subset of patients who are who are kind of slow or late responders. We have seen, say, after third injection, they start responding.
Yes.
There are certain patients who, by the first injection, second injection, they don't respond, but after the third injection, they start responding in the terms.
Yes. This was a very impatient patient. Yeah. So after switching, when he started losing vision, he immediately wanted to go back to Eylea. Yeah.
And
Hmm.
about your third case, yes, CSR could be the one of the most probable diagnosis in a young patient. Other could be a trauma also, because trauma
Hmm.
patients sometimes behave like that or have a CNVM grown from that areas mostly.
Yeah. Actually, I've
Uh,
been seeing his father also, and his
hmm,
father has macular degeneration in both eyes with secondary CNV in one eye and teardrop
hmm.
sign, typical that you see with chronic CSR. So I don't know if it's some kind of
Mostly,
and
yes, CSR. But yes, I keep the trauma in the young patient also as a DD.
yeah,
Other is, yes, of course, a choroiditis or a secondary CMVM like that, or a old history of choroiditis or something like that. But your patient didn't have any suggestive findings of that except for, yes.
yeah,
That would be.
no findings of
Uh,
choroiditis. Yeah.
any further questions for the first presentation? Okay. Then I think let's move on to our next presenter, Dr. Rohan. Please present your cases.
Thank you.
Yeah, I hope I'm audible and my slides are visible.
Yes, sir.
Thank you. So at the outset, I'd like to thank Bayer for giving me this opportunity and Dr. Juneja sir for those kind introduction. I'll be juggling through a little bit of theory and two of my cases in my 19 slides. Uh, I have one case which is a treatment naive case, very basic case of how I start usually Eylea and how patient responds very well to Eylea. And second one is kind of similar to what Dr. Grover showed, where the patient had received a lot of ranibizumab and how Eylea did well in that case. So we all know that basically war against AMD is like a war against time. We have to reduce the treatment burden while maintaining the vision gain, and whatever time the patient doesn't come back or whatever damage has happened, it is kind of very difficult to get back to the original form. We know if left untreated, permanent loss of vision occurs very rapidly after the onset of symptoms in a AMD case. It was View 1 and View 2 study, which, in 2012 told us about aflibercept, where they showed that how in a case of wet AMD, giving aflibercept even bi-monthly is as effective as ranibizumab, which was injected monthly in this study for a neovascular AMD case. And if we go back to theory, why basically aflibercept works a little bit better as compared to ranibizumab is because of the multiple action on multiple VEGF as well as placental growth factor. We all know that brolucizumab and ranibizumab it act on VEGF-A, while we have VEGF-A, VEGF-B as well as placental growth factor acting and leading to all the VEGF load. So aflibercept blocks a VEGF-A as well as VEGF-B and platelet and placental growth factor, and which contributes to the downstream pathological effects controlling the disease. So my case one is, so I saw this patient last year. He was an 80-year-old gentleman, came with reduced vision, basically left eye from 2 months. Right eye, he wasn't concerned, told me that his vision has been less in right eye from past 10 years. His visual acuity was counting fingers close to face in both the eyes. This was his right eye. You can see it's in a pretty bad state. The macula has a lot of IRF, lot of SRF. You can see some hemorrhage also. And this was the eye he was concerned about. You can see we have subretinal bleed along with some shrum material over the macula, and OCT showed us a lot of intraretinal fluid with some SRF and this subretinal hyperreflective material which was present. I diagnosed him to have wet AMD and decided to go ahead with Eylea. He was a treatment naive case. He had never shown anywhere, never injected before. This was approximately, let's say, 4 to 5 weeks after first Eylea, where his visual acuity in the left eye improved to 2 meters. We can see how the subretinal hemorrhage had started to resolve, and we can see the details of the fovea more clearly. We can see how there's some scar material present all around the fovea. And similarly, OCT showed a pretty good response after one Eylea, where that huge amount of intraretinal fluid had reduced. The shrum was getting more concise, the PD had reduced, and the margins of the shrum was also looking a little bit more clearer. Decided to go ahead with a second Eylea injection. And this is, 4 to 5 weeks after second Eylea injection, where he had improved to 20/200 now. Most of the subretinal hemorrhage which was there had resolved. There were few specks of subretinal hemorrhage present above and nasal to the fovea with this scar tissue. And OCT also showed almost complete resolution of intraretinal fluid with this fibrovascular PED, this subretinal hyperreflective material. And I went ahead with third Eylea. It was a very compliant patient, took third Eylea, improved to 20/125. The subretinal hyperreflective, the macular scar was still there. Hemorrhage, just a speck present nasal to the fovea. And OCT also showed us very good response. You can see there is complete resolution of intraretinal fluid. There is no subretinal fluid. There is some shrum-like material, some PED present. And so I injected him the last and the fourth Eylea. And this is what he had presented to me around a month back, where there was no hemorrhage present anymore. There was just some scar tissue. The shrum material had completely become well-defined. The margins were well-defined. There was no fluid present, just some PED present. And now I've asked him to review after 1 month, where I'll see and decide about the further injections. So ViewRetina, basically, this was an education platform, ViewRetina, where they showed that it is just not the need of anti-VEGF treatment which is unmet, but there is an unmet need for reducing the treatment burden. So we have to extend the treatment of the injection so that we can reduce the burden of these anti-VEGF agents on our patient. And various studies have shown us that there is variable amount of VEGF-A suppression in the patient with aflibercept as well as with other anti-VEGF agents. You cannot exactly fix for how long an anti-VEGF anti-VEGF works in a patient, and you have to individualize the treatment depending on how the patient responds. But yeah, usually I always follow a loading dose of 3 injections followed by try to go ahead with a treat and extend regimen. But in all clinical practice, it usually doesn't happen this way because the patients are very compliant with the follow-ups. So we all know how treat and extend regimen works. You have to treat initially until the patient becomes stable, the fluid has completely gone. And after that, you extend the interval with 2 weeks. Dr. Juneja just told us that he becomes very aggressive and he extends with 1 week, which is also a very legitimate way to work. What the theory says is you extend with 2 weeks. I follow 2 weekly extension and keep on giving him injection, usually extending it till maximum 16 week until the fluid recurs. And if it recurs or the visual acuity declines, we again go back. We again reduce the interval between the injections and we again try to maintain him at a particular duration where there is no more fluid and the vision is maintained. So now another very small case, which is not a treatment naive one, and he initially came to us in 2023. Another 80-year-old gentleman presenting visual acuity of 20/80 in left eye. You can see how there is this intraretinal fluid present, some amount of subretinal fluid also present at the margin of the PED. And initially he was given eccentrics, and this is after one eccentrics where his visual acuity remained stable, but his intraretinal fluid did show very good response. We can see almost everything has IRF has completely resolved almost. There are few there's some cystic spaces also present, and this patient was then asked to be on a loading dose followed by a treat and extend regimen. So over next 15 months, he was not very compliant with the follow-ups, but he used to come every 6 weeks, 2 months, whenever he used to feel some reduction in the vision, and he had received over 9 eccentrics in past 15 months. And this is when I saw him approximately in 2025 last year, where his visual acuity had actually reduced to 20/200 after giving 9 eccentrics. And there was massive amount of intraretinal fluid with those hyperreflective foci, some amount of SRF, which can be seen at the edge here. You can see this PEDs and all those features which are not very, not a good prognostic marker. And that is when I decided to switch to Eylea. After giving one Eylea, this is OCT 1 month post Eylea, his visual acuity improved to 20/125, and there was massive reduction in all the intraretinal fluid. The SRF had again, completely gone. There was some shrum, there was a PED, and again I asked him to, review after 1 month so that we can re-inject. But this patient again got lost to follow-up. And he presented again after 6 months. He told me that for 6 months, his visual acuity was completely fine with just one Eylea, despite receiving 9 eccentrics before. And this time he again came back with visual acuity of 20/200. You can see the intraretinal fluid has come back. You can see the shrum, the pigment epithelial detachment. And I again gave him his second Eylea. Again, very good response with his visual acuity improving to 20/100 parts. The IRF resolved. You can see some shrum. And now I've kept him on follow-up, asking him to review after 1 month so that I can give him further injections. Just a word about PCV before ending. We know PCV is the more sinister brother of wet ARMD, and aflibercept is generally the preferred agent for PCV also. There is no level 1 evidence, but we have seen that aflibercept has a stronger binding affinity. It acts on more growth factors and it has a longer T-half. So it has an added advantage over ranibizumab, I feel. And brolucizumab definitely can work in refractory cases. So if you have a case who is not responding to aflibercept and ranibizumab, you can try brolucizumab. There's a caveat of intraocular inflammation, but studies have shown that we as an Asian population, because of a genetic pharmacokinetics, we have some amount of protection as compared to Caucasian population. But I only use it in refractory cases, and it is not my first choice of drug for PCV as compared to aflibercept. Thank you for your patient listening. I'll be happy to take any questions.
Thank you, Dr. Rohan, for very crisp cases, actually. Again, a non-academic question. This logo is of CL Gupta. Is it of CL Gupta?
I'm presently working at CL Gupta, sir.
Okay, okay.
I
used to visit
finished
this
my
center.
fellowship from LB Prasad and then I joined CL.
Okay, okay. So because I knew this logo from the CL Gupta at the time I used to visit over there. So, okay, coming to the cases part. Yes, you rightly mentioned about the VIEW studies, basically, which showed us that the bi-monthly injection of aflibercept is, say, better than ranibizumab injection. In fact, these few studies, which actually established the role of aflibercept as like that, and especially the treat and extend which you follows, that was basically Altair and Aries basically, which showed us the role of Aries, which helps us in showing that treat and extend even after say 24 weeks is as equivalent to say after 96 weeks or say something like एक साल के बाद उसको करने की बजाय 48 weeks before that. And Altair also helps in the establishment that treat and extend gives the actually the same advantage or the same amount of vision improvement in comparison to the loading doses, and of course reducing the number of injections for the patient. In your second case, yes, when I was talking about na, ki I take say after every 5 weeks I call such patients for treat and extend. That is especially in the cases like your second case, basically
Yes.
where the eccentrics has been given multiple times, and we know that all the three negative biomarkers like IRF, SHRM, and hyperreflective foci were present, and all the your second cases were there from all the eccentrics injections. But yes, in those cases, I normally go for say 5 weekly. Otherwise, yes, mostly my treat and extend regime is 6 weekly. But that patient, yes, we you have seen in the second patient that he needs aggressive treatment. And aflibercept, yes, is a drug to go in such cases. However, PCV, I sometimes differ. I sometimes start even with brolucizumab in PCV, especially if it is a bilateral PCV, which we find a lot in Indian population, especially the Asian population. And yes, intraocular inflammation is the chances of there. But yes, in Asian population, yes, thanks to our genetics, it is quite less. But both the cases are great, and the way you have managed them. First was a textbook kind of case, which you managed it beautifully by. I was just looking at when does your injections pause. So after the fourth injection, you paused for a while to check it out because the SHRM has totally subsided, and of course the macular edema has totally gone, IRF is totally gone, hemorrhages is totally gone. So only the scar marks is what is left. But yes, these disease or these the patient with having these two or the bilateral things, they come aggressively back. So you have to be on twos always, keeping them under a regular follow-up and chain. So
Yes, sir.
thanks for
I think counseling is very important when it comes to these cases. I always
always.
tell them three things at the presentation. One is that you will require lifelong injections. Nobody has
Yes.
been able to tell you what is the end. Even bigger studies, everyone has just said there's no end to it. Although I do tell them that initially the load might be high, and maybe after 1 year the number of injections will go down. I always tell them that do not expect more than 10, I mean, 2 lines of improvement, to be very honest. That is what studies have told us. You can go up to 10
Yes.
letters, go up to
Exactly.
2 lines. So I always kind of tell them that, you have to realize that your vision, we are more trying to stabilize rather than improve. If we get an improvement, we will be very happy. And
Exactly.
definitely we need to say that it is an urgent situation. We can't sit over it.
People are now beginning to understand because of the increasing geriatric population. Howsoever, the load is such that in most of the cases, our insurances doesn't apply for that. Hardly one injection or two injection might come to most of the people. The rest of the injections are a big deal. And thanks to aflibercept, people lowering their prices, they are lowering their prices in India. Now it has come handy. So this treatment nearby and telling the patient that you need Eylea injection, it, say uh, 6 months before, it takes the guts to say and to make the patient go for it also. Now the things are yes, little different and conducive to the patient also, and to us also a great help because we know that a molecule which has done good work can be
Yes.
given or people can afford it now. However, I'm waiting for Eylea HD so as to see the 8 milligram result. At least it can give us a wider time period, time or injection free zone.
Yes, sir. Agreed. It will help us at least reduce the treatment burden, uh,
Yeah.
increase the gap between
Anytime.
the injections.
Yes, yes. Any further questions from anyone?
So, doctor, in your first case where you decided to go for the fourth injection and then having a pause after that fourth one, what was the exact reason for that? Because usually we go for the three loading doses and then we see the response. So,
Uh, Dr. Arya, I had given 4 injections, and for past 2 visits, I mean, the hemorrhage had completely resolved. One thing, his visual acuity was stable. He was
Mhm.
he was not having any more metamorphopsia, and OCT in past 2 visits was not showing me any signs of activity in terms of IRF or SRF. Uh, that is the reason basically I called him after a month to see that how he responds if we just take a break. The
Okay.
patient is pretty compliant. He's not somebody who will return to me after a few weeks. That is something which I judge when I stop injections for any wet AMD case. But
Okay.
probably because the activity was not there from past 2 visits, I decided to just give him a holiday break for a few weeks.
Fine, fine. Nice to do, because that case was very nicely managed, and I believe the patient had a vision gain. What I feel is like after first or second injection they have a better vision gain, and after that the visual prognosis is not that good, although, but the clinical findings and the OCT picture, it becomes improving well. So
I think it's very opposite to BRVO. So if you have a BRVO case, they'll be very happy after first injection. Your wet AMD case will be very happy after 3 injections. So this uncle was very happy after receiving 3 injections because he was close to face. He is 21-25 parts. BRVO will say, "अरे sir, first injection में सब दिखा, second के बाद कुछ नहीं हुआ."
BRVO is like a child improving from 85% to 90%. And the next day, the parents expect, oh, it has to be 100%, which is not possible.
true. Truly, sir.
And it's a more forgiving disease, of course. We know that. Huh?
Yes. Nice, but
Uh,
the cases are really
the
very nice and
response in
motivating.
Thank you. Hello, am I
Yeah,
audible?
yeah. Doctor.
Yeah,
Yes.
yeah. So in my experience with BRVO is very variable, sir. Some cases they don't need the repeat injections. They improve even with one or two. In some cases, no matter how many injections you keep giving, they have to keep getting repeat injections. They keep coming back with edema again and again. So
But
I
still,
think
mostly
depends
the
on a
vision
lot.
is preserved. Yes, of course, it depends upon a lot upon the ischemia and the other factors. But yes,
Yeah, yeah.
at least the vision is there. Not like NMD where the central part whole goes like that.
True.
And the
Yes.
patient is not left with any useful vision in the sense of driving or reading or writing. All the major works are affected. That's the main issue.
Yes.
Uh,
Eh,
thank. If there is no further question, then we'll go for the third presenter, Dr. Riddhi.
Yeah, good evening, sir.
Yeah, please go ahead with that. Your presentation.
I'll just, this presentation has to be, yeah, okay. I'm trying to share.
So in Dr. Rohan's cases, we have seen how even with the scarred CNV, how patients can still improve. And yeah, it may be useful to treat even patients with scarred CNV and
Yes,
some.
yes. It is always useful to
Yeah,
treat and you have to counsel very well. So actually, that's why I was saying the first case was a textbook case where the improvement was good and he treated in a nice manner. So patient was also
yeah.
compliant. He made him like that. Oh,
Mm.
Dr. Reddy has started sharing.
Yeah.
Finally, I could manage to share my screen. Very good evening to all of you, and thanks, Bea, for giving me the opportunity to present my cases. So, I'll be presenting 5 short cases basically. This is again the AMD cases, or the traumatic AMD, traumatic CNV, I'm sorry. So, my first case is a 19-year-old male. He came to us with a diminution of vision in his left eye, and at that point of time, his best corrected visual acuity was 6 by 24 when we advised him injection, and he was lost to follow up. He didn't go anywhere and didn't receive any injection. came back again with the vision of 1/60, and he received 2 ILIA from our side. So it was the first presentation when he came, and I advised him ILIA in the very first visit. And this was when he was lost to follow up and came back again. So the size of the lesion was increased with IRF, SRF, and the shrimp. So when he was injected with the 2 ILIA injections, and this was the final the OCT picture, where the lesion, definitely the fluids have come down, but scar is there. So as sir said, that the central vision was gone, but still patient was having a better vision what he was having earlier before injections. I am presenting very shortly because of the lack of the time. So this is the case 2. It's a 66-year-old male patient who came with a vision of 6/24 and in his left eye, and he took the ILIA injection. I gave him 3 doses, 6 weeks apart, although not the 4-week regimen I follow in his case, and he got a vision of 6/12. So it's the picture at the time of the presentation, where we can see a massive SRF, IRF, and the hemorrhagic PD. Sorry. And this is at the 1 month follow-up, 6 weeks follow-up, where the fluid has come down and the lesion was decreasing in the height, as well as the hemorrhage was clearing. This is again after some week. However, I see a increase in the PD in this picture after that, and he received another injection and the lesion came down. But again, he had this scar, and at this point the patient was lost to follow-up. He didn't come back because I was planning another injection in the same eye. The third case is a 67-year-old female. She had a diminution of vision in her right eye since 2 years, and she had received 3 injections earlier at another clinic. And when she presented to me, I gave her 2 injections 4 weeks apart. This was the picture at the presentation. She had a massive exudation, IRF, hyperreflective foci, shrimp, PEDs. Every finding we can see in the picture. It's such a massive exudation. It came down a little bit, but then the elevation and the fluid, the shrimp, I see in the superior temporal part, it was not coming down with the injection. However, other lesions were shrinking up, and the visual, she was gaining few letters of the vision in visits. And this is the final presentation. However, this OCT is not covering the superiotemporal aspect, where the same elevation was present even after 3rd injection. This we can see. So that my question in this patient is that how long should we continue for the injections? We can be discussing it. Fourth case is a 72-year-old male. He had the diminution of vision in his left eye for 5 years. He had received few injections earlier elsewhere. He was maintaining a good vision, and he is one of those patients who very diligently come for the follow-up, and whenever they feel that something is not good with their eye, they come, they get their OCT done, and they just right away enter in my OPD and say, I need an injection. So he received 2 injections, and recently he got another injection, and the time is always 3 months or 3 months 1 week. When the disease, he feels that the disease is coming back, and he receives another injection. So it was at the time of the presentation, and the shrimp is there. However, the IRF keeps coming and going with the injection, and the duration is 12 weeks that I have noticed in his case. And the 5th case is a 68-year-old male, diminution of vision in the left eye for past 2 months, best corrected visual acuity 6/60, I gave Eylea 10 weeks apart in the 2 in number, and he regained a vision of 6 by 36. One line improvement was there in his eye. I have only octa picture of this patient where we can see the reduction in the fluids and the vasculature, the network is shrinking in the size. So my experience with Eylea that I have extended the duration of between the 2 injections from varying from 4 weeks to even 12 weeks. I have seen that the patient remains stable for a longer duration of time, and if they are really very keen on getting a follow up and injection, they come and they get injection again, they maintain the vision. So, but my query in this case, where really I want to know how long should I go and inject injection in this patient's eye. So if anybody can help me with this. Thanks.
Thank you, Dr. Reddy, for
Thank you,
short
sir.
and crisp 5 cases. Okay, coming to your the first case,
Yes, sir.
the trauma one.
Yes, sir. Yes, sir.
The post-trauma, this is the typically the classic type 2 kind of situation over
Yes.
here. And how many injections were given in this patient?
2 injections, sir.
Okay. But is still there, lost to follow-up or something like that?
Patient came where I didn't see any fluid in his eye, and he was not very regular with the follow-ups. That's why he lost his vision to 1 by 60.
Mhm.
So after 2 injections, he didn't come. He came late. I saw there was no fluid even after those many months. So I didn't give the third injection.
Due the last OCT, which is shown basically here, which has got a small amount of IRF over there,
It's very
along with the
small.
hard
Yeah. But he didn't
along
come
with
for
the
the
hard
injection.
exudates and little amount of SRF. I could feel because it's a you can say small window. Otherwise, there is SRF at the edge of the lesion, basically
Mm-hmm.
the part from which. So I believe yes, this basically needs more injection. And this and the trauma patients actually behave very good with such kind of injection with the classic CNVM.
Mm-hmm. Yes, sir.
Uh,
So that was my plan, but I counseled him also when he presented to us with the first picture. What I think we could have saved the vision when if he could have gone for the injection in the same sitting, but
hmm,
he came quite late. He presented in October and then he came in June with the second picture.
okay, that's the thing. Okay, we have got a question from the audience as well. For a name for PCV patient with a large packed polyp cluster and significant SRF, should we not favor brolucizumab upfront for its aggressive polyp regression rates, or start with aflibercept and reserve broly strictly as a rescue therapy for recalcitrant one? Your take on this, Dr. Rohan?
Sir, I think rolizumab is not a bad option when it comes to such kind of presentation, and I'll be okay to start rolizumab also, but I think I'm a little reserved when it comes to that intraocular inflammation because I've seen 1 or 2 cases, and
Mhm.
in my practice, and those patients were not very happy. I
Hmm.
mean, it's very difficult for that patient. It was very difficult for me to tell that patient you need more injections. It was very
Okay.
difficult to counsel him that, okay, that this inflammation can be managed just with some prednisolone eye drops. But he was looking at those 2 patients, I decided, okay, brolucizumab may not be my first choice when it comes to even a very, aggressive PCV patient. Unless the patient definitely understands, okay, we might need some treatment if the patient develops some inflammation. If the patient understands, then yes, brolucizumab is the first one for me. Otherwise, I leave.
What about you, Dr. Apurv?
Yes, same, sir. I have seen inflammation, although the incidence is rare, but in the patient who develops inflammation, it is very difficult for you to convince them that you did not choose other drugs where cause of where the likelihood of inflammation was lower, but instead you went for brolucizumab. But if the patient develops inflammation, then it is very difficult to explain to the patient, and then you will lose the follow-up, they will lose their vision. So it is always, I prefer it for recalcitrant cases and not as first time,
Dr.
even
Riddhi,
though the incidence is
any-
rare. But yeah.
anything you want to add, Dr. Riddhi?
Same, sir. We'll go with the Eylea first, like this Aflibercept first, and then if it is not responding well, then we'll go for the Brolucizumab. Not in the first this thing visit.
Because the question was actually naive PCV patient with large packed polyp cluster. Most of these patients who present like that, they have a vision less than 660 or less. I normally go ahead with the brolucizumab early in such scenarios. Yes, I do reserve aflibercept along with that. But yes, in such scenarios, after talking, like Dr. Rohan said, yes, after talking and explaining to the patient that this drug might give us a, you can say, faster response or the faster resolution of the PCV earlier on, that we might be able to shift to the much, you can say, safer drug later on in the future. I normally go ahead with the first choice in such scenarios. Well, specifically in this question which he has asked. Otherwise, yes, my go-to drug in PCV or ARMD is always like aflibercept. But Broly in such, yes, where packed polyp cluster, significant SRF, vision less than 660, I feel there are less to lose rather than any other thing. Yes, a famous thing from a famous keh raha hu, the kind of thing which happened to me in two cases where I had a reaction with brolucizumab. One patient, both eyes were going brolucizumab. One eye recovered beautifully. The other eye had intraocular reaction after the second dose of brolucizumab. But fortunately for the patient, after the inflammation subsided, his disease went away in that eye, and the other eye is still receiving the aflibercept injection as such. That was but the thing which I noticed it for the first time. Okay, the disease gone, the inflammation occurred, and the disease gone along with that. Yes, and Dr. Aishwarya Dhawan has also asked, afraid to give the loading dose of brolucizumab. Yes, I even if in such kind of patient, if I give, I take minimum say 6 weeks to 8 weeks time between the two dosage. But minimum is 6 weeks. But yes, 6 to 8 weeks is my go-to time in such kind of scenarios. Dr. Riddhi, you were asking about your third case, na?
So,
Yeah, it looks like a PCV kind of situation with a probably a peripheral आपका उसमें फोटोग्राफ में probably नहीं है but a peripheral PSCR जो हम बोलते हैं basically peripheral exudative lesions also. What do you feel, Dr. Rohan, in that scenario? The
Yeah,
third case about the PCV.
Dr. Riddhi, can you just share the slide and show me the case once?
yeah, sure. Just a moment. This is the. Is it visible?
I mean, your slides are visible. Yeah. Yes. Okay. This is the case where you were asking when should we stop. So I
Yeah,
think
because
yes. I mean,
yeah. Please go ahead, please.
no. I mean, I agree with sir. It's most probably a PCV case, and there are. I mean, the ideal way I think would be, which is difficult to do, but to get an ICGA, see the polyps, see they are active or not. I mean, if they're there or not, or and if they're there, you keep on injecting. I mean, that is what the studies say. If there are polyps present, you keep on injecting till the polyps go away. But for all practical purposes, I do not practice that. It's very difficult for a patient to keep getting ICGA every monthly or after every 6 weeks. So I usually, if this is the last OCT which I'm seeing here on my screen, where
Yeah.
all right, this is the one. So this is the one where you can see that in the fundus photo, I can't see any hemorrhage.
No.
And the OCT, I don't see very active SRF or IRF, although there's a huge PED. Maybe, you would have given 5-6 injections by now, and
Yeah.
maybe this is the time when I'll just take a break and see him after a month. When I don't see any hemorrhage, I don't see any SRF or IRF, and or rather do an ICGA and inject once more and see again. That is the ideal way.
Because I stopped because all the hemorrhages were resolved. The exudates were becoming sharp in the margins, and there was no fluid in the OCT. So I thought that this is a good time to stop and see the results, how the disease is progressing in the further follow-ups.
You
I
did the
agree.
right thing, Riddhi, Dr. Riddhi, but the fact is, these cases do tend to come back aggressively. And suddenly, one fine day, you might find a hemorrhage or subretinal hemorrhage exactly at the macula or at the margins of these hard exudates kind of thing. So you have to be little more aggressive. What I feel in such kind of scenario, you have to be little more aggressive in your follow-ups. And with the slightest inclination, say increasing of any amount of IRF, any change in the size of the PED also sometimes gives us a clue. Along with, yes, of course, SRF, but SRF is generally, you can say, it's a merciful thing, I would say, in comparison to the IRF or these kind of hyperreflective foci. So, but you have to keep these patients under very close follow and inject at the slightest indication of any disease activity. I know it has been not possible. ICGA, a lot of people, we might not be having ICGA.
We don't have it in our
Dr.
center.
Rohan might be having in the CL Gupta, that's a different issue. But in the private practice, very rarely you will find ICGA.
We
OCT,
don't
Octa, still. But again, the patient a lot of time doesn't actually go ahead with the ICG or FFA in such kind of scenarios because he or she has become aware of the disease and they know कि हाँ जरा सा भी है डॉक्टर साहब इंजेक्शन दे दीजिए अगर वो मतलब he is that kind of person so he or she
that
will
is
himself
that is my fourth case, but this patient is reluctant to get any other injections because if we see clinically उसको कोई improvement feel नहीं हो रहा है vision में. The central
we
vision is
understand
earlier.
but at least he has a field of vision.
Yeah, he has a field of vision.
मतलब this is what the science says. Okay, practical, whatever happens in the clinic, it's a different ball game. But so what the science says is two things. One, you have to be very aggressive with these kind of patients for the follow because they may turn nasty any point of time with this disease. And secondly, inject as soon as you find any chance of recurrence.
Right. That's right.
In ideal scenario, you'll inject till even the PED goes completely down.
Yes.
That's what
Yes.
the
Ideally,
textbooks
yes.
do. If there's a PED, you inject. You get the PED also down. Or having a new onset PED is another indication of activity. You re-inject if you see a
Exactly.
new onset PED.
Because the previous OCT didn't have this PED or a big, huge PED like that. Yes, exactly.
It
So
has.
Yes.
this had, after that, it slowed, it came down. And second last slide, which you showed in this one, see, there is no PED. And this last has increased in the PED again.
Yes, sir.
So basically, this needs aggressive treatment. It will come back, that is for sure.
Then maybe the scan is not taken from the same
It is,
spot.
yeah, that's what I told it, that the scan was not
Yeah.
passing through this part. It's the
Where
vector
the
is in
PED
a
is.
different
Could be.
direction.
Yes, could be. But still,
Because
Yeah.
if the scan is passing to this part, then the PED height in the one scan before it is also roughly the same, or it has increased more than that.
it is almost the same, sir. It's
Okay.
decreased from the first follow-up,
Mhm.
but it is consistently the same all throughout.
Probably, yes, then. But you have to
What is his
aggressively follow.
vision? What is the patient's vision at the final follow-up at this stage, Dr. Riddhi?
Was it patient came with finger counting 1 meter, I think.
And then
Okay,
after
yeah,
the
one
injections
minute.
also,
It was, yeah, it
it
was, the vision was same. The vision was not improving at all.
Of
yeah.
course, these
So
patients are
that
bound to lost to follow-up actually.
yes, exactly.
There's a lot of
Because
scar tissue subfoveally and there's a lot of shram. So vision was not improving, although the OCT picture was improving.
yeah, yeah, and that is why they will be reluctant to get more injections also.
Exactly.
My go-to choice in this
So
scenario would be Broly in first instance. Because if the
Okay.
patient is coming with that 1 meter vision, he has actually nothing to lose.
nothing much to lose. Yeah.
Yeah, right.
So
That's a good point. Yeah.
that's what I was talking about a naive PCB. But this is also not a naive PCB patient. He already had 4 injections
Had,
before.
yes. She already had.
That's the thing. So I think if there is any other questions, okay, no questions in the talks, the chat box also. So I think
Recently,
Dineshji,
sir,
that's the end of the day. And thanks, Dr. Apu, Dr. Rohan, and Dr. Riddhi for very crisp cases and for a good and longer amount of follow-up, so that we could have we were able to discuss the long-term follow-ups of such scenarios. Yes, aflibercept is a say drug of choice in such scenarios, especially in the AMD and PCV, and with the rates coming down also, it has become easier for us so as to make people understand the utility of a drug which acts on more than one receptor, and of course which helps in earlier and faster resolution of the things. Over to
So,
you, Dinesh.
yeah, thank you so very much, sir. And I really want to thank you, sir, for driving the discussion so well and that intense discussion to discuss each case by case. And actually, that is the objective of these closed group meetings, to have sharing of experiences, and also it is a learning for us also, like how you treat your cases, and that's how we also learn from your cases. So thank you so much, sir, for driving the discussion so well, and involve all the panelists and our speakers. Thank you so very much. And I would also like to thank our speakers, Dr. Apu Grover sir, for 2 excellent cases, and also Dr. Rohan Kapoor sir for nicely managed case, and the kind of textbook cases, and also Dr. Riddhi Arya for 5 short cases. So thank you so very much for all your cases. And I would also like to thank our attendees, all the doctors. Thank you so much for attending this meeting. And I hope, sir, we will disturb you again and again to have this kind of meetings where we can have some learnings from each one of you. So with this, sir, I really thank each one of you, sir. Thank you so very
thank
much,
you so
and
much.
good night.
Thank you
Thank you
all.
for having us.
Wish you a good night to all of you.
Thank you. Good night.
Good night, sir.
Good night.
Good night.
Thank you so much, sir.
Thank you so much.
sir. Good night, sir. Good night,
Bye-bye.
Bye.
Okay, sir, can we end the session?
Yes.
Yes.
Okay, sir.